This is an interesting case of a traumatic pediatric splenic rupture. This was a 13-year-old male who presented to the emergency department with abdominal pain, status post a bicycle injury. He basically says he fell off the bike and the handlebars stabbed him or jabbed into his abdomen forcefully. Primarily, his pain is in the epigastrium, worse with movement and deep breaths, and then radiates to his left shoulder. Denies any other GI symptoms, any chest pain, any shortness of breath. He was wearing his helmet. There was no head injuries or loss of consciousness. There's no medical or surgical history. He's received all his pediatric vaccine. On exam, his heart rate is 117, noteworthy. His blood pressure is 121/71. Respiratory rate is 22, slightly elevated. His oxygen saturation and temperature are normal. He's laying on his left side, holding his abdomen, and appears uncomfortable. His HEENT exam is normal, neck normal, cardiovascular, he's a little tachycardic, otherwise normal. Respiratory is normal. His abdomen reveals diffuse tenderness, greatest at the left upper quadrant, with rebound and guarding and quiet bowel sounds. Extremities normal, and the rest of his exam was normal. In the ED, he had 2 peripheral IVs placed, and labs were sent, and he was given some morphine for his discomfort. He's noted to have a white blood cell count of 19,000, a hemoglobin initially of 13.1, and normal platelets. The rest of his labs were okay. Point of care ultrasound was performed, which is here on the right. This is a FAST exam, or focused assessment of sonography and trauma, and his FAST was positive. So what we're looking at here is a long axis view of the right kidney. Great picture. See the liver sitting above it. Okay, so this is the hepatorenal space called Morrison's pouch. And then what you see here is all this hypoechoic stuff. In the setting of trauma, this is presumed to be blood. So that's why it says free fluid. And you can just catch the glimpse of the diaphragm here. But this is a positive FAST exam in the setting of trauma, suggesting hemoperitoneum. So trauma surgery was consulted, and because the patient was relatively stable, a CT scan was ordered. And a repeat CBC 2 hours later showed that he dropped from 13.1 to 11. Let's talk about blunt trauma in pediatrics. 90% of pediatric trauma is blunt and the number one cause of death, although in the US, gunshots appear to have overtaken that. Mechanism of injury typically would be falls, bicycles, ATV, motorcycle, cars, sports. Can occur in isolation or, of course, in a multi-system or multi-organ trauma. Intra-abdominal trauma should be suspected with handlebar or seatbelt injuries. Spleen is the most commonly injured organ following blunt trauma and can range from just a hematoma to lacerations, fragmentation, or complete devascularization of the organ. Trauma can be minor. It doesn't have to be a profound mechanism. Some minor mechanisms include falling off of a chair, hitting the edge of a table, or even a strong ocean wave. On the right side here, we see one example of blunt abdominal trauma evaluation. And just really briefly, it starts with suspected blunt trauma within 6 hours of injury and normal GCS. Are they unstable? No. Then you go through the algorithm here and consider labs and CTs. If they are unstable, you give them a bolus. If they continue to be unstable, you have to do a FAST exam, and then you consider blood products and surgical intervention. However, if they stabilize with some fluids, you move into the imaging algorithm back into the sort of ATLS type of pathway here. History and exam. The cardinal signs of blunt abdominal trauma, or splenic rupture, I should say, include left upper quadrant pain and tenderness. First sign, which our patient has, is left shoulder pain due to irritation of the diaphragm by the hematoma, which irritates the phrenic nerve and causes some radicular symptoms to the left shoulder. Comorbidities which suggest intra-abdominal trauma include femur fracture, so a really profound long bone fracture, and hypotension. Normal examination does not exclude intra-abdominal pathology. If you have a high index of suspicion, you may require imaging or serial abdominal exam. Laboratory evaluation would typically include a complete blood count, a complete metabolic panel, a UA to look for hematuria, type and cross in case you need blood. And serial hemoglobin is valuable for monitoring the severity of their injuries or any early signs of decompensation. The focused assessment of sonography for trauma, which is what our patient had, is useful to detect intraperitoneal fluid. It's much more specific than it is sensitive, meaning that if there's blood there, you're pretty confident there's an intra-abdominal injury. However, absence of blood does not entirely exclude pathology. CT scan is, of course, more sensitive and would be considered the gold standard for evaluating any abdominal pathology, especially solid organs like liver, spleen, and kidneys, but not hollow viscous organs such as the stomach, pancreas, and bowel. Management is non-operative if possible, as most of these are self-limited. Splenic preservation does reduce the risk of post-splenectomy infection. So stable patients can be managed with bed rest, serial abdominal exams, vital signs, and hemoglobin monitoring. Some patients in the sort of middle road category can be treated with interventional radiology guided arterial embolization, so they need an intervention but not necessarily surgery. And then reasons that they would go to the operating room would be massive disruption or hemodynamic instability, or if there was some other injury in the abdomen that needed to be addressed surgically. Conservative management has good outcomes, with the vast majority of kids having a full recovery. And then on the right here, you can see one example of not one example, this is the splenic classification. So grade 1 being the most mild, and you see a small amount of surface area involved, not that much depth. And then as you move from 1 to 5, you see much more dramatic lesions here. You see devascularization in a grade 4 of half or so of the spleen. And then grade 5 is the whole thing is obliterated. These patients are probably going to be very sick. And you can make this diagnosis on CT scan, or you can make this classification. So in the case of our patient, he had a grade 4 splenic lac, which extended into the hilum with significant intraperitoneal hemorrhage. However, the decision was to admit him to the surgical service, perform serial abdominal exams and hemoglobin, and the lowest he ever dropped was 7.5. So he did well with conservative management, went home on day 5 with the instructions to avoid strenuous physical activity, and had a good outcome in follow-up. So 3 key points about traumatic pediatric splenic ruptures. The first is that following blunt trauma in pediatrics, the spleen is the most commonly injured intra-abdominal organ. Left upper quadrant pain, tenderness, and referred shoulder pain, also known as Kerr sign, are the classic findings of splenic rupture, with CT scan being the imaging modality of choice. And the vast majority of cases do well without surgical management unless there is massive splenic disruption or hemodynamic instability.